So today we're going to be doing a barium enema. We need our barium bag, our pole, our barium, our air infuser, our balloon inflator, our tip of course, the lubricant, hemostats in case you need them, our gloves and some towels. So now I will be getting my patient. Daisy? Hi Daisy, my name is Annabelle. I'll be helping you today. So can you verify your first and last name for me?
Daisy Palmares,
And your date of birth?
October 18, 1957.
Thank you. Is there a chance of you being pregnant?
No.
No? Do you know what we're doing today? What procedure?
Yeah, the doctor kind of explained it to me. Yeah.
Okay. He gave you something to prep for today?
Yeah.
Like your bowel movement?
Yeah, yesterday I took it.
Okay, perfect. So I'm gonna have you change into the gown, and I'm gonna have you remove everything, including your underwear, and then I'll explain the procedure to you.
Okay, sounds good.
Thank you. So prior to the B procedure, we are going to take a scout image to indicate how well the patient prepared for the exam, and that would be shown to the doctor, and he will instruct us next. You ready?
Yeah.
Okay. So I'm going to explain to you a bit about the procedure. We are going to put contrast in your colon to see what's going on and what your problem is, and then the doctor will tell you the results. Okay?
Okay.
So now I'm going to show you how we start the procedure for the doctor. Before we start, we want to make sure that our balloon inflates and stays inflated, because we only want to tip the patient once. We want to make sure that our bag is 24 inches, no more than 24 inches above the rectum. And we also want to bleed our bag to see if everything flows through fine and smoothly. And we are also going to clamp at the very end after we've bled it. And it would be at the end so that we don't have a lot of air going into the patient. Now, once we would lubricate the tip, and we would insert the tip 1 to 1.5 inches anterior and then superiorly, and we would not want to go more than 4 inches inside of the rectum. So I'm going to lubricate my tip. Okay, Daisy, we're going to feel some pressure, okay? Just relax. Let me know if you have any pain or if you feel very uncomfortable.
Okay.
So I'm going to go in and take it. So now I'm going to inflate the balloon. You're going to feel some pressure, okay?
Okay.
And then for this part, you can also use the hemostat just to make sure that it stays inflated and in place. Just like that. Okay, are you feeling okay, Daisy?
Yes.
Okay, thank you. Now after that is done, I would call the doctor and let him know that the patient is ready. So now that the radiologist is done, I am going to start my overhead images. Since my patient was left on her right side, we're going to start off with the right lateral decubitus. I have already put my IR on her and behind her, and I put my left marker on top because that's her left side is up. Now I'm going to bring the decubitus, I would have my patient hold her breath and take the image. Now I'm going to go into a PA oblique, which is going to be in her RAO. Now for this one, we are going to be using the table bucket. So I'll help the patient. I will run my image. And grab a new cassette. Are you feeling okay, baby?
Yeah.
Okay. So I'm going to be placing my left marker So here are our ideal barium enema routine images. We are going to start off with the right lateral decubitus. Now for the right lateral decubitus, we want to use a 14 by 17 IR. Want to be at 40 inches distance. Our central ray is horizontal and perpendicular to the IR, and it is centered to the mid-sagittal plane and at the iliac crest. We want to see the entire colon. Now for the right lateral decubitus, our medial side of the ascending colon is of interest, and the lateral side of the descending colon is of interest. So our next image would be the PA oblique in our RAO position. Now we want to also use a 14 by 17, be at 40 inches distance. Our central ray is 1 to 2 inches of the midline to the elevated side at the iliac crest. Our patient is rotated 35 to 45 degrees to see the colic flexure with less superimposition. Since this is our RAO position, we want to see the right colic flexure with less superimposition. Here's our left colic flexure, our descending colon, our ascending colon, and our sigmoid, which is here. So our next image would be the PA, which is again 14 by 17 IR at 40 inches of distance. Our central ray is running through the mid-sagittal plane and at the iliac crest. Here we want to see the entire colon again. Here is our ascending colon, transverse colon, descending colon, our right colic flexure, our left colic flexure. Here is the sigmoid. So our next image would be the PA axial. We would use a 14 by 17 or a 10 by 12. We are using again 40 inches of distance. Our central ray is 30 to 40 degrees caudate and runs through the mid-sagittal plane, and it exits at the asses. Now here we are only, our area of interest is the rectosigmoid area. Here's our rectum, and then here's our sigmoid. That's why we can use a 10 by 12 because we are looking at a smaller section. And the 30 to 40 degree angle does help decrease the superimposition of the sigmoid curve. Now our next image would be our PA oblique in LAO position. Again, we are using a 14 by 17 IR, distance of 40 inches. Our central ray is 1 to 2 inches to the medial line, to the midline of the elevated side at the iliac crest. Our patient again is rotated 35 to 45 degrees. And since we are in our LAO position, we want to see the left colic flexure with less superimposition. Here is our right colic flexure, our transverse colon, ascending colon, descending colon, and here is our sigmoid. Our next image is our left lateral decubitus. Again, a 14 by 17 IR is used. 40 inches of distance. Our central ray is horizontal and perpendicular to the IR, and it's centered to the mid-sagittal plane at the iliac crest. Now here we are looking for the lateral side of the ascending colon. That's our area of interest, and also the medial side of the descending colon, which is here. Our next image would be the left lateral rectum. For this, we would use a 10 by 12 IR. Again, 40 inches of distance, and our central ray is perpendicular and at the mid-coronal plane at the level of the asses. Now here we are again just looking at the rectosigmoid area. That's why we can use a smaller IR. Here's our rectum, and then here's the sigmoid. And finally, we would do our PA post-evac image, which would be the same 40 inches of distance, 14 by 17 IR. the central ray runs through the mid-sagittal plane at the iliac crest. And we also want to see the entire colon. And you can see that the barium is running down. Then we can see some large colon pathology. Here we can see an image of diverticulum, which is there's like ticks that grow outside of the colon, which you can see here. Then we see here polyps, which are growth from the mucous membrane. So you can see these little dots here, these little specks. Those are what polyps are. And then we can see ulcerative colitis, which is inflammatory ulcer in the colon. So as the inflammation increases, the bowel wall and haustra thicken, which results in a loss of normal haustra markings. You can just see here that it just runs smooth. You don't see the haustra structures of the colon because of the inflammation.